John Flaherty. I am a chiropractor in Pawcatuck, Connecticut.
So Dr. Flaherty and I met when I first came to town. We realized we have very similar professions and we would probably eventually be working together a lot. He's been really helpful with a lot of my patients. He's been a good resource for us, and he's been treating spine patients in this community for a long time. So when Dr. Flaherty called me and said that his son injured his knee, that was one of the first times I did a house call in a while in my pajamas to help him out with his son's knee issues. So I'm glad he's doing a lot better.
They were actually like...
They were flag pajamas, American flag pajamas.
That's right.
He liked them.
Yeah, very
he
patriotic.
He made a comment. He thought it was very good. I do mostly spine surgery, probably 80 or 90%, but I also treat a lot of general orthopedic conditions too. So, one of the advantages of coming to our group is that we all kind of have that background, right? We all have a lot of experience in other orthopedic issues as well. So when John told me that his son hurt his knee, we got him keyed into our group pretty quickly. We got an MRI quickly, got a diagnosis within a couple days. Being a part of this group, I have partners who can take care of things when they need other types of surgery. So in this case, he needed ACL reconstruction. So I sent him one of my partners.
I was very impressed with the whole from A to Z of it. Like, it was seamlessly done in that, he got in right away. He was then seen by, appropriate specialists. The testing that he needed done all got done like in a super timely fashion. It was, it was great.
And he's back to rowing, you said, right?
He is back to rowing. He is ahead of schedule, I think, by some metrics. And he has you guys to thank. I do believe in a cooperative approach to things. My expertise is probably getting people out of acute pain more so, and then getting them appropriately plugged into the proper channels. But when you're dealing with that stuff, that's when I love to rope in physical therapy and occupational therapy. I mean, I'll manage people with exercises and give them advice to get through their immediate thing, but when they're talking about actually getting better at a sport, increasing their capacity to do things, I love referring out and working with other folks.
Yeah, we collaborate a lot. I mean, there are a lot of people who come to see me and it's very early on in their treatment course, right? So, more often than not, I think that, people benefit from more physical therapy, chiropractic care, medications. And it's nice that we have such a personal relationship where, if here I have somebody who really needs something more and needs it quickly, we can refer to each other within a day or two usually to get people in.
It depends.
Yeah.
So if someone has very specific criteria and symptoms, they're going to automatically want to go there first. Mm-hmm. In a situation like that, where I might benefit is I might be able to take someone in more immediately, make the phone call on their behalf, get in his ear ahead of time, and sort of like, get the doors open for them so they're ready and prepared. And that's when things are real hot, right? We're talking bowel and bladder dysfunction, severe myelopathies, really yucky things. But when they're dealing with pain, even horrible pain, I think I'm good to get in there because sometimes I always tell you this, I'm the low-hanging fruit guy. I pick all the low-hanging fruit off the tree, that stuff that's easier to deal with in like not a musculoskeletal setting, which never will end up in his office. So if you can get someone within a few treatments and really get them down, moving better, feeling better, there's a good chance he might not see them. But then there's all the in-betweeners who there's a crossover. Like I want them to go get seen, get checked by ortho, maybe do some additional testing. So who to get to first, it just depends on what's wrong with somebody.
Well, and a lot of time too, like, you and I have a lot of mutual patients. So, we've kind of treated people who get intermittent flare-ups, right? And right. You and I both kind of tell them what the plan is, right? So, I'll have patients who have had, therapy, chiropractic care, injections, who I'm like, look, if you tweak your back, strain your back, and you're having a lot of muscle pain and spasm, you should call Dr. Flaherty, right? If you're getting, really raging sciatica symptoms that responded well to an injection before, give me a call, right? So we have a lot of patients who we kind of have this established treatment plan to kind of settle down their symptoms in a predictable way based on what they've responded to before.
You can have an overlapping sacroiliac pattern of dysfunction and a radiculopathy.
Right.
So sometimes something like that would be a nice combined approach.
Or people have a neck and a low back issue, right? So, if I'm treating their neck for something and you're treating their low back for something, you're both kind of uniquely working on different aspects of their spine care.
Communication with the group and with Dr. Wagner has been great. And that's what's really helpful too, is being able to just pick up the phone and speak to someone right away about someone's care. It just helps. It just helps on a lot of levels. We're besties.
We are.
Can we read do you guys have a handshake?
We don't have a secret. Look, we can't show
should
you
work
that.
on
It's
that.
really secretive.
The cameras are rolling right
I was
now.
going to say, that's like our special thing that I don't think I can share with the general public.
Okay.
It's always movement based, right? That's what keeps people well. I mean, we have acute treatments and modalities that help people get back to function. But I would say, as a general statement, for people to stay well and maintain well, it's things that happen outside of our office. It's, eating well, moving your bodies differently. The quicker you get people back to their activities of movement, exercise, daily living, the better the outcomes long term.
Sure.
So being able to expedite care and coordinate care early in the front end is really important.
Yeah, actually, that's true. I mean, I talk to patients about that all the time. A lot of times when people are really in an acute setting, and you and I talk about this sometimes too, but people ask for things like braces, right? A brace is, in general, unless you have a fracture or a ligamentous injury, is probably not a great option for people because it kind of promotes you being sedentary. It limits your mobility more than anything else, when in fact you want to get more mobility back. You want to work on strengthening. High-speed injuries, car accidents, usually it's best just to go to the emergency department to get that sorted out. And there's usually somebody from our group on call in the emergency department at any given time too. If it's something where it's kind of an acute issue, but similar to symptoms that you've had in the past, we often, base your treatment based on what you've responded to in the past. If it's something new, our group can usually get people in within a couple of days for, twisting injuries or lifting injuries or things that are a little bit lower energy. I think your schedule at your office is pretty similar, right? Your schedule is an open schedule, right? So if people have an established relationship with you for a condition that you've treated in the past, they can usually just make an appointment with you online or within a day or two to get, treatment for it. But I definitely think it's important to engage with your provider early on just to make sure that you're doing everything in your power to get better quickly. It's okay to give it a day or two of rest. It takes some over-the-counter medication. But if things aren't getting better on their own, it would be in your best interest to reach out to a provider, to get an evaluation, at least get some basic imaging.
The answer is, it depends.
Yeah, right.
Because if you get into the walk-in clinic and the person you get, so, the box of chocolates, the philosophy, the person who understands spinal care, ortho care, they may appropriately refer right then and there to who they got to go. They'll differentiate care. And if you get someone who's not familiar with it, then it gets weird. I had a patient 3 weeks ago, who acute onset of non-radicular back pain, very uncomfortable, made their way to a walk-in center, and then they immediately referred this person to a neurosurgeon. And it was a 6-week wait to get to the neurosurgeon. I just happened to randomly meet this person in a non-clinical setting, and when this guy was telling me his tale of woe, I finally was I couldn't hear it anymore. I asked him questions, and I'm like, you don't need to see a neurosurgeon for that. And neurosurgeons probably don't want to see you for this.
So I see a lot of people who come in kind of early on in their treatment course. I think it's a good idea to establish care early, just to get baseline imaging to make sure that there aren't any congenital problems. They don't have a baseline deformity in their spine. Just make sure that some of the treatments that we would recommend are safe and appropriate for them too. And then, once we kind of get that baseline, then we start talking about, options for treating their condition, right? So what Dr. Flaherty does with his manipulation and, giving people a home exercise program is immensely helpful in, I would say, 90% of the cases.
I'll give you a specific that I run into frequently. I find more spondylolisthesis than, probably people think there's spondylolisthesis out there, because they just stay hidden until that one time when it starts to flare up in their 30s, 40s, 50s. And if they're going online and just doing the standard low back exercises, or their friend goes to yoga class and tells them to do the cobra, like it doesn't always work out well. So getting people in right away, getting them imaged, evaluated, just to kind of get a baseline of what they're at. Then you can intelligently tell them what to do or what not to do.
Yeah, actually, that's a good point. If they have an unstable spondylolisthesis, like 90% of the exercises that we do for lumbar strain are contraindicated. So spondylolisthesis is when the joints in your spine degenerate, or in younger people, if they have a defect that they were born with, that results in a progressive shifting of the spinal segment over time. So what that can do is it can cause back pain. It can also cause neurologic symptoms. So people sometimes get shooting pain that goes down into the legs. So people with normal spinal alignment who have muscle issues but don't have shifting or scoliosis, they typically respond very well to strengthening programs and a gradual return to activities. But when you have a higher grade shifting in the spine, it's much more likely to get to the point where you get persistent symptoms despite those things.
PJ is much smarter than I, so I just tell people, you have like Legos in your spine, like Legos, and if you lifted one of your Legos up, moved it over and clicked it down, that step off, that's a spondylolisthesis.
That's a good way to describe it. I'll probably use that from now on.
See, he knows what I'm talking about.
Yeah, people get Legos. So the good news is there's lots of good treatment options for this problem. But once you start getting the shifting in your spine, usually results in the need for injections or surgery down the line. We have to figure out what the underlying problem is in order to intelligently discuss precautions and treatment options for them, right? But for the vast majority of people with acute muscle strains, for example, in their neck or in their low back, one of the most important things is to get some anti-inflammatory medication on board and just get them moving and into some appropriate treatment, which usually involves a combination of physical therapy and chiropractic care. I also talk to people about nerve pain blockers as well, which is an option if you have really bad sciatica or nerve pain coming from your neck. Beyond just what Dr. Flaherty and I can do for people too. We have in this group people who do injections in the spine, right? So, if Dr. Flaherty has somebody who thinks would be appropriate for an injection, sometimes, we can collaborate on the side and just kind of go over the case and, get that sort of treatment expedited for them without, necessarily even coming to see me, because we have other practitioners in this office who can kind of give them what they need. That's one of the benefits of having a good close personal relationship with providers in the area, and just also having people who live in this community too, right? So Dr. Flaherty and I both live in Stonington, so we treat people in the Southeast Connecticut, Southwest Rhode Island area. So they're not only our patients, but many times they're like our neighbors, or friends of friends.
And
right?
people have been very appreciative of having good ortho care in this area.
I think so.
Having you guys down here has been really...
Yeah, I think it's just one more service that we can offer to people in this area that, maybe was something they had to travel really far for before. It's a multidisciplinary approach to try to resolve people's symptoms early on, right? So the more practitioners we have in one group and in the community who kind of offer different things, then we're kind of attacking the problem from different angles. There's really not a whole lot of ambiguity anymore with advent of readily available MRI, right? So 30 or 40 years ago, when MRI was maybe not as accessible, a lot of spine surgeons used to base their diagnosis on physical exam and typical nerve root distribution in the legs, or if they had subtle weakness in muscle groups. We're still doing that, but then we're thinking in our brains, okay, what would I expect to see on the patient's spine MRI? And then you're looking at the imaging and kind of confirming the diagnosis. So it's just one more corroborative piece that sort of makes things a little bit less ambiguous.
I have a need less often for advanced imaging as a non-surgical provider, right? It's usually if a person I'm working with in a that kind of a setting, let's say my magic number is always 3 weeks or 4, 5, or 6 visits. If I can't make an obvious, really good change or see things change, not that they all get better in that time frame, but see something positive happening, then I start to worry like I could do this 50 times and it's not going to happen, or I'm looking at referring or imaging,
High-speed injuries, car accidents, usually it's best just to go to the emergency department to get that sorted out. And there's usually somebody from our group on call in the emergency department at any given time too. If it's something where it's kind of an acute issue, but similar to symptoms that you've had in the past, we often base your treatment based on what you've responded to in the past. If it's something new, our group can usually get people in within a couple of days for, twisting injuries or lifting injuries or things that are a little bit lower energy. I think your schedule at your office is pretty similar, right? Your schedule is an open schedule, right? So if people have an established relationship with you for a condition that you've treated in the past, they can usually just make an appointment with you online or within a day or two to get, treatment for it. But I definitely think it's important to engage with your provider early on just to make sure that you're doing everything in your power to get better quickly. It's okay to give it a day or two of rest. It takes some over-the-counter medication. But if things aren't getting better on their own, it would be in your best interest to reach out to a provider, to get an evaluation, at least get some basic imaging.
The answer is, it depends.
Yeah, right.
Because if you get into the walk-in clinic and the person you get, so, the box of chocolates, the philosophy, the person who understands spinal care, ortho care, they may appropriately refer right then and there to who they got to go. They'll differentiate care. And if you get someone who's not familiar with it, then then it gets weird. I had a patient 3 weeks ago, who acute onset of non-radicular back pain, very uncomfortable, made their way to a walk-in center, and then they immediately referred this person to a neurosurgeon. And it was a 6-week wait to get to the neurosurgeon. I just happened to randomly meet this person in a non-clinical setting, and when this guy was telling me his tale of woe, I finally was I couldn't hear it anymore. I asked him questions, and I'm like, you don't need to see a neurosurgeon for that. Neurosurgeons probably don't want to see you for this. And then I kind of directed this person appropriately, and they're doing all right.
That's a good question. The short answer is it depends. A lot of our answers say it depends, right? So a brief period of rest after an injury, spinal injury, either a neck strain or a low back strain, is always a good idea, right? Most things get better with anti-inflammatory medication and a brief period of rest. It's when things are getting worse or you start to develop nerve symptoms like shooting pain that goes down into the legs or into the arms, that's usually a reason to seek out treatment from a spine provider. I think everybody in this room probably has had an issue with either a neck or a low back strain, right? So, in my case, my most recent one was literally just looking to the side, and I had acute onset of neck pain that lasted for about 20 minutes and got better, right? So if I had called to make an appointment with somebody like Dr. Flaherty 5 minutes into my symptom course, I would have called back again 20 minutes later to cancel that appointment, right? So it's okay to give yourself a brief period of rest and to see what happens. But it's, pain that persists more than a couple days, or if you get, numbness or tingling in the hands or feet, or if you get really severe shooting arm or leg pain, those are indicative of more significant findings that probably would prompt some sort of evaluation by one of us.
I'd even go a step further and say, it never hurts to be evaluated.
Yeah.
People who come to my office don't necessarily come and get treatment.
Yeah.
They sometimes get evaluated and then validated that you're okay. This seems to be a normal course of it. You're going to be fine. Keep doing what you're doing.
Yeah. Call me if this happens.
Call me.
Right.
And then the algorithms that we use to look at people go to movement. So it's sort of independent of symptoms, right? You can feel good, you can feel bad, and you can have dysfunction present. So it's looking for the dysfunctional patterns that determine whether or not you should do something to someone or not. I had one today. It was fine. Just a little low-grade soreness, and couldn't find anything wrong with this gentleman. And, I was very pleased to say, I don't need to do anything to you.
Yeah.
Get out of here.
All right.
I think it's important, and I do it a lot with you. For example, I'll find spondylos, right, what we talked about. And sometimes, I'm able to treat them, get them in exercises, and then they're fine. So they don't necessarily probably need more care beyond that. However, I will encourage them at their convenience. It's not always not urgent. I love them to get in there because the questions I want them to ask, I load them, and I hope they ask you the same questions. What's my long-term strategy here? What does this look like 5 years down the road, 10 years down the road, and then what are my options? Because if you are in a case where there would be a high probability that down the road something could be maybe need to be addressed surgically, but not now. Do you want to wait until you're 94 and, really struggling in life with poor bone mass, or is it something better done earlier? So I think it's just having a plan, right? Asking the adult questions in the room about what the immediate versus long-term, strategies are. It's important.
If I get this symptom, these are my options, right?
Yeah.
So like empowering patients to have a better understanding of their problem so that they know how to efficiently treat it, right? So if there's something that we've done for them in the past that worked and they get similar symptoms, they know who to reach out to first, When people have multiple musculoskeletal issues, one of the big things is to make sure that they're not having referred pain from their spine, right? So Dr. Flaherty and I see a lot of times people who maybe present with leg pain, they think they have like a knee issue and we think it's a back issue, right? So we're like referred pain from your back. So it's important to figure out those things, or the same thing with the cervical spine. If they have arm or hand issues, we're always thinking in the back of their minds, oh, could this be referred pain from the spine? But if there's multiple other things going on, I think that's even more important to get more providers in the mix, right? So, in addition to a lot of the patients that he and I share, we also have a lot of patients who see other people within our practice or other people in the community too. There's not going to be, for people with multiple musculoskeletal complaints, there's not going to be one answer for their problem. But you're going to have a lot of providers who give unique perspectives about all the things.
That's where taking a good history and giving a good exam is valuable.
Yep.
If someone rolls their ankle, they're in a boot, they're hobbling around for 3 months before their back starts talking to them, that's probably a good indicator that it's stemming from something like that. A lot. More and more as we travel, and I think medicine is getting better and evolving, is people are working more as an interdisciplinary approach. So like the Venn diagram is closing. So PTs, OTs, chiros, orthos, massage, athletic trainers. There's more and more like overlap I see with, physical therapists are trained a lot better now and differently than they were 20 years ago. Now they can take people in primarily and they differentially diagnose. That wasn't always the case. It's now the case. Everyone's a doctor now. There's also with that a recognition of the connectivity of things. So it's not so separated, like you go see chiropractic for this or physical therapy for that, or like there's an overlap. And I think inherently with that is people are recognizing how everything is affected. Your gait's affected. If your feet are flattening as you get older and you're overpronating, that's affecting. If you're suddenly used to do more variable sports, like you played soccer for a decade and a half and then all of a sudden you started just going to the gym and when your kids are making you crazy and all you do is treadmill running, that's different. There's muscular patterns, there's imbalances that come with that stuff. And people are much more acutely aware of that today.
I also think those are fun patients to care for because it's kind of like a mystery. It's a puzzle you're solving, right? I like people coming in with non-specific complaints and you kind of got to figure it out.
Especially the runners when they bring in their 4 pairs of shoes.
Yeah, I like taking care of runners because they always want to get back to running. Like that is it's an endorphin thing. It's a quality of life thing. Like they're very motivated. So athletes in general are a lot of fun to take care of. It's an addiction.
Oh, it's a good addiction.
Yeah, exactly.
Yeah.
Well, first off, it's hard to tell a runner not to run in general, right? So that's a difficult conversation to have no matter what, because they don't like that answer. I think a better way to think about it maybe is the goal is to get people, this is for a lot of orthopedic conditions, but the goal is to get people back to doing all activities that they want to be able to do comfortably somehow, right? So whether or not, whether it's with therapy, medication, injection, surgery, like that's our whole goal is to get you to do those activities comfortably. Like I never want to tell people that they shouldn't do things. My goal is to get their symptoms to a degree where they can do things that they need to be able to do to be happy. After a while, the warranty on the human body starts to wear out, right? But your orthopedic surgeon is here to fix the problems that start to wear out. If it's a car, you need new brake pads. When you get older, arthritis sets in and sometimes you need a new hip or a new knee, or sometimes you develop a disc herniation that needs surgery. So that's kind of the goal here is to keep the car running as long as possible.
My spouse, we recently had an issue. She was seeing a provider and sort of not complaining, but why this is and kind of lamenting, why is this happening now? And the provider's like, oh, hon, like, we're not supposed to live this long. We're all in new territory here. Like, basically, it was the suck it up buttercup speech. We'll get you back there. Don't you worry.
Did you ever watch the Louis C.K. show? He walks into Charles Grodin's office, who's this like curmudgeonly old doctor. He goes, my back hurts. Can you help me? And the doc's like, no. Like, he gives this whole long spiel about how we're not supposed to be walking upright. He goes, I'm not gonna be able to help you. Come back and see me when you have like a blood disease. That's what I train for. If people have a complex problem, it's more important to have a lot of different providers who have unique perspectives and unique things to offer people, right? Because, in that specific instance, it might be not entirely clear what the best option for them is, right? So, different people have different opinions about things, but you want to have all the options available for people on the table so that they can kind of choose a treatment path that works best for them,
I frequently answer this. People, when we talk about possibilities, if this doesn't work, what the next price step would be, and if that doesn't work, what the next step might be. Trying to give people some perspective. And usually, if you're talking about as surgery is always like usually a last resort, but a possible option. And the idea of fusion comes up. Immediately, everyone jumps to, I'm going to lose range of motion, and then I heard it's just going to be a bad show after that. So many years after, it's going to be back in the same boat. And I tell people that statistic is probably true in generality, but it doesn't tell the whole truth, because the truth is that people are camp A and camp B. People who get that new lease on life, because fusions are time tested. They've been doing it for a long time. They work. Period. You go in feeling like dog dirt. You come out like, wow, I can't believe how much better you are. Okay. And by the way, Tiger Woods won a Masters.
With a spinal fusion.
Yeah. Like I always tell people, like your golf game, unless it's better than Tiger's, you'll probably be okay. Make modifications to lifestyle, really get good advice and start working their bodies better, eating differently, approaching things better. I have never seen any studies that differentiate between that and the other group, who just goes back to the same thing that got them there in the first place. They all get averaged together. And yeah, there's a statistic that you have a better chance of getting a second surgery after having a first surgery, but I don't think it tells the full truth. Because my experience from doing this for 25 years now is that group A does really, really, really well for a long time.
Yeah. I mean,
would you agree with that?
Yeah. So, what that doesn't take into account, I think, sometimes is when people have really severe nerve pain that has, failed everything else, you literally can't do anything in your life, right? So your option on the table is better than living with that severe nerve pain. And in general, like you kind of alluded to, the technology is so different than it was even 20 or 30 years ago. People are getting back to work, getting back to daily life quickly.
Or just back to movement.
Yeah, back to doing anything, not sitting on the couch.
Walking around.
Right.
That's a whole different thing than you're on your back for 60 days before
Hospital length of stay after spinal fusion is much lower than it used to be. Yeah. People are getting back to work faster, so technology is a lot different now. Let's talk about yours first.
I'm going to give that one to you, because there's not a lot of changes in my profession.
Well, just talk about some of the cool things that you do, though.
Cool things. So going back to my Venn diagram theory, I love quoting me. Modalities like dry needling has been something that added in the last, I would say 8 years for me, has been a really big, helpful thing. I pushed it off for a while, but I'm really pleased with what you can do with people. I'm always excited to learn about more rehabilitation type things. That's like where I feel like as a chiropractor, I did not get, at least back when I was in school, we didn't get nearly enough of it. Then I got into practice and I realized I had to really kind of ramp myself up for that. So that's always fun to go and get some good, shoulder rehab and different ideas. But that stuff very much overlaps with many other professions, because like now I'll go to seminars and there'll be like physical therapists in with me or vice versa. And, I think the real big changes are coming in your neck of the woods.
So that's one of the exciting things about spine surgery in general, is that it's very cutting edge. So we're doing a lot more things with robotic navigation, so CT guided navigation, which helps us to do surgery really safely and efficiently. Disc replacement devices are another thing that are becoming more and more popular, so as an alternative to spinal fusion. So those are the things that are really exciting.
Could you explain for us, the uninitiated, who I was very impressed when I actually finally got to play with a robotic surgical instrument. I have patients who think robotic surgery is that a robot comes into the room and literally does the stuff.
No.
So could you speak to that?
Sure. Robotic technology in spine involves getting a preoperative CT scan that looks at your bony anatomy. Anytime people need a fusion operation, it's an option for people to help to pre-plan your screw trajectories, see exactly where the instrumentation is going to go based on people's anatomy. And then in the operating room, when I'm doing the surgery, I'm using a robotic arm that comes into the surgical field and helps me to navigate the screws based on that CT scan. So before the surgery, what I'll do is I'll pull up the patient's CT scan, I'll plot out exactly where the screw is going to go, what size it's going to be, and it helps me to, once I'm doing the surgery, execute the plan that I came up with before. And it's a good option for a lot of people to minimize surgical time, minimize radiation risk in the operating room. It improves screw accuracy. You can also do things minimally invasively too, so it requires a much smaller exposure. So the incision is much smaller than it would otherwise need to be if we didn't have this technology available. What that translates into is being able to do surgery really safely, but also helping people to recover faster than they ever have.
So I think robotic surgery is a terrible name for that. What I think it should be is virtual reality surgery.
Well, that's the
3D
helmet.
surgery.
That's an option too. Did you hear about that?
No, I want to.
Don't put this in the video because it's not approved yet. So draw little lines out when you're looking around.
Are there frickin' laser beams involved?
There's frickin' laser beams involved.
So cool.
That's
Yeah.
so cool.
Yeah, it's awesome.
I would like to very much thank the Orthopedic Partner Group and all the doctors through the years that I've been working have always had this wonderful and comfortable feeling that when I run into a problem, I have a patient who's really in need, they always have done well by me. They always just pick up the phone, they'll call you back, they take good care of people, and it's been a very, very positive experience. So I very much appreciate everyone at Orthopartners.
Oh, you're gonna make me blush. I really love you too. No, in all seriousness, I've been very happy with our relationship. We're friends outside of work. We collaborate together a lot professionally. Dr. Flaherty has always been available for me for people who come into my office who I think need his services quickly in order to get better. I always tell him that he makes me look really good because all I do is write a referral with his phone number on there, and then they come back a few weeks later and they think I'm a genius when I really didn't do anything except give them your phone number. So I appreciate it.
Well, that goes both ways. But yeah. Actually, we had one last week. Within 10 minutes of leaving your office, you contacted me. I reached out to them. And then they basically...
They drive from here to your office?
20 minutes of leaving your
Yeah,
office.
that's great.
Yeah.